All righty. I'll just give it a couple more minutes before we start the case study. All righty. Let's see what time it is. All righty. Good morning, everybody. I hope everyone can hear me. I am Dr. Russell Brown, and we're conducting our monthly case study review for uh, um, with Avinia Behavioral Management. Today, we will be talking about transgender youth. And just for the record, I use two resources. One is Case File Case File Psychiatry, the sixth edition by authors Toy and Clayman. And we also use Psychiatric Case Studies for Advanced Practice by Prendergast and Jackman. So I'm going to go ahead and get started. This is case number 7 in the Psychiatric Case Studies book entitled Transgender Youth. We'll go ahead and start. Identification. The patient is a 14-year-old adopted African American female to male transgender individual. The patient uses the name Joseph and masculine pronouns he, him, and his. Um, he is evaluated in a child and adolescent inpatient crisis unit. So he's in the CSU. Uh, Chief complaints, quote unquote, my parents don't understand me. Um, uh, Let me view the lobby, make sure, get some more people in. All right. Uh, History of chief complaint. The patient came out as a transgender on social media about 2 years ago. At that time, he asked his parents and friends to call him Joseph and to refer to him using masculine pronouns he, him, his. He wants to wear only boys' clothing. He uses the boys' bathroom at school and participates in groups and activities for boys. The patients report that his parents are not accepting of his transgender identity and that they lack any acceptance. Um, any acceptance and their lack of acceptance has contributed to him having increased anxiety and depression, even suicidal ideation. The patient told his outpatient therapist that he was planning to kill himself um, um, by running out into oncoming traffic. The therapist contacted his parents, who then brought him into the hospital for evaluation or brought him into the CSU. The patient reports uh, engaging in self injurious behavior by making superficial cuts to his arms and occasionally to his breasts because I hate them. I don't want them. The patient reports that his last episode of self injury was about 2 nights ago, where he used a razor to cut his left forearm. Um, he reports, I can't seem to focus and that he is in danger, of failing 2 of his classes at school. He has been sleeping most afternoons after returning home from school. His patients, the patient reports feeling very sad for the last month. He states he's been eating more than usual and has gained about 10 pounds in the past month. He's currently being prescribed fluoxetine 40 milligrams by his outpatient psychiatrist. Past psychiatric history. The patient has been in outpatient therapy off and on since the age of 4 because of anxiety and issues with gender identity. He's had several trials of medication for attention deficit hyperactivity disorder as a young child. He is currently taking Prozac 40 milligrams with some effect on his anxiety and depression. They also had in-home family therapy for about 6 months following a referral from the patient's school. This therapy ended about 4 months ago, and this is the patient's first psychiatric hospitalization presentation. Medical history. The patient has exercise induced asthma and several superficial healing cuts on his left forearm. History of drug and alcohol abuse. The patient reports smoking about 5 cigarettes per day. Um, he denies any use of alcohol, marijuana, or any other illicit substances. He denies use of any unprescribed hormones also. Family history. There's limited information about the patient's biologic family, but there were substance abuse problems um, uh, noted in his biological mother, and we don't have any specific information about the substances that were abused. The patient's adoptive mother does have a history of depression. So let's go to personal history. Perinatal, unknown because the patient is adopted. Childhood, the patient was adopted at the age of 5 after having been in foster care since the age of 3 because of neglect and physical abuse by his biologic mother. No other children live in the home. The patient began to express cross gender identity at the age of 12. He insisted on wearing boys' clothing and used the boys' bathroom at school, even though the school did not permit this. Adolescence, the patient expresses distress at developing secondary sex characteristics associated with females. He's currently binding his breasts to create the shape of a flattened chest. He reports intense dysphoria around the time of menstruation. He's currently attracted to girls and identifies as heterosexual. Trauma and abuse history. There was physical abuse and neglect by the biological mother um, from birth to the age of 3, which led to his being placed in foster care. Mental status examination. Appearance: short hair, dressed in masculine clothing, wearing eyeglasses. Behavior and psychomotor activity. He's somewhat restless, bouncing his right leg throughout the assessment. Consciousness: he's alert. Orientation: he's oriented to person, place, and time. Memory: this was not formally assessed but appears to be intact during this assessment. Concentration: he reports impaired concentration but appears mildly distractible um, and appears mildly distractible during the assessment. Visual spatial ability was not assessed. Abstract thought not assessed. Intellectual functioning um, was average. Speech and language rapid and mildly pressured. Perceptions: no evidence of any perceptual disturbance. Thought processes: these are coherent and goal directed. Thought content: no abnormalities. Suicidality and homicidality. Uh, he has a suicidal ideation with a plan to run into traffic uh, um, with uncertain intent, but he does have a plan. Mood is down. Affect is congruent with mood and is constricted. Impulse control. It was good during assessment. Um, his history of self-injurious behavior may be, however, an indication of his recent impulsivity. Judgment, insight, reliability, or fair, moderate, and moderate. All right, so let's start formulating a diagnosis. And the question is, which diagnosis should be considered? Um, the author here states the first diagnosis should be major depressive disorder, severe single episode without psychotic features. And then we have an additional diagnosis of gender dysphoria in adolescents and adults. Um, all right, so we all should be familiar with the symptoms of major depression, and so I won't list those out. But what is the rationale for this diagnosis of major depressive disorder? The patient meets criteria for major depressive disorder because of decreased mood over the past 2 weeks, along with some loss of energy. He reports decreased concentration during that time. Hypersomnia, he comes home from school and and goes to sleep. Hyperphagia, he's been eating more and has gained weight. Low self esteem, and he has the suicidal ideation. He denies any symptoms of mania or psychosis. The symptoms are contributing to distress as evidenced by his self harm, and his mood is not attributable to any substance use or any medical condition. So he meets the criteria for the major depressive disorder. Um, let's move on to the second diagnosis, which is gender dysphoria in adults and adolescents. And I will go over these diagnostic criteria. There are two components. A, there has to be a marked incongruence between one's experience or expressed gender identity and the one that's assigned. So there's a difference between how you feel about your gender and the one that's been assigned to you from birth, genetically or anatomically. And this has to occur for at least 6 months. You have to have this discordance for at least 6 months. Um, and it's manifested by at least two of the following characteristics, and I'll read six of them. There has to be a marked incongruence between the experience or expressed gender uh, and the primary or secondary sex characteristics um, that the person displayed. Um, so there's a difference between um, how you perceive yourself gender wise and your secondary sex characteristics, such as deepening of your voice, the budding of breasts, menstruation, etc. Two, there's a strong desire to be rid of one's primary or secondary sex characteristics because of marked incongruence with one's expressed gender. So um, you would want to, in this case, like this um, individual, they're flattening their breasts. Um, they're they have a lot of dysphoria around menstruation because they're inconsistent with what he perceives his gender to be. Number three, there's a strong desire for the primary or secondary sex characteristics of the other gender. So obviously, uh, this individual cuts their hair to look more like a boy uh, and avoids characteristics that a young girl would want, which would be to have her hair long, um, etc. Number four, there's a strong desire to be of the other gender or some alternative gender different from one's assigned gender. So once again, if it's a biologic girl, there's a strong desire to be a boy. Um, Five, there's a strong desire to be treated as the other gender. Um, Six, there's a strong conviction that one has the typical feelings and reactions of the other gender, um, or some alternative gender different from one's assigned gender. B, um, the B criteria, the condition is associated with clinically significant distress or impairment in social, occupational, or other important areas of functioning. So, what's the rationale for this diagnosis of gender dysphoria in this individual? One, uh, this patient meets the criteria for gender uh, dysphoria because he has expressed a cross gender identity, female to male, for the past 2 years. So he meets the 6 months time duration. He's expressed a strong desire to be a male and to be treated as a boy. The patient exhibits at least two of the required diagnostic criteria and experiences significant distress in his social functioning and therefore meets the criteria for this diagnosis. All right, what tests or tools should be considered to help identify the correct diagnosis? They state here you have the Beck Depression Inventory, the Patient Health Questionnaire (PHQ), and or the Mood and Feelings Questionnaire, the MFQ. Obviously, these would only help determine the depressive disorder and not necessarily address assessing the gender dysphoria. Um, what other differential diagnosis or diagnosis should be considered? Here they state none, um, but I'll address that in a minute. Uh, Actually, I'll go ahead and address that now. In the second book, they do talk about the differential diagnosis in in gender dysphoria, and and here they state in the second book the most common issue in the differential diagnosis for gender dysphoria is recognizing simple non-conformatory with stereotype sexual behavior. So, for example, this includes, being a tomboy as a girl or being called a sissy as a boy. These are just mild variations that kids may have as they're growing up. But gender dysphoria goes far beyond this type of behavior that we may see in children. Um, when a girl's labeled a tomboy or a young man is labeled quote unquote a sissy, there's a profound disturbance in the patient's sense of identity regarding being a male or female. So uh, when they border more into the gender dysphoria or gender identity disorder, um, the idea of who they are, how they identify themselves, is really the key. Um, and this is why the DSM-5 made the child diagnosis stricter and required more than just gender non-conforming behaviors. Um, so actually, the child would literally have to say, you know, I am not a girl, I'm a boy, and the boy would literally would need to say, I am a girl and not a boy in order to meet the level of gender identity disorder as a child. At the same time, the criteria for adolescents and adults has become more inclusive, allowing for non-binary transgender adolescents and adults to receive the diagnosis uh, and subsequently access to care. And this generally states that an adolescent, they may say, well, I'm neither a boy nor a girl, uh, and they refer to themselves as they or us or we. It gets a little complicated, um, but you can still meet the definition of gender dysphoria if you if you are non-binary, meaning that you don't claim to be a boy or a girl, um, but you don't you don't ascribe to your anatomical or your gender assigned identity at birth. And the book also goes on to state that homosexuality is not seen as a psychiatric disorder. Um, uh, Transvestic fetishism, another thing that should be considered in the differential, is cross dressing in the clothes of the other sex, but this only serves to create sexual excitement. Patients displaying these behaviors generally do not have the other symptoms of gender identity disorder, such as childhood cross gender behaviors, and their gender identity matches their assigned sex. So, a male that cross dresses, um, he knows that he's a male, he wants to be male, he's attracted to females, but he just gets sexual excitement out of wearing women's clothing. Um, Also, in the differential of gender identity disorder is schizophrenia, and delusions can occur in patients where they believe that they are members of the other sex. However, these individuals with schizophrenia actually believe that they are members of the other sex, whereas patients with gender identity disorder usually say that they feel as if they are members of the other sex, but do not actually believe that they are. So that's the difference between schizophrenia and gender dysphoria slash gender identity disorder. Um, so, formulating the treatment strategy here, which treatment would you prescribe and what is the rationale? All right. Um, in the Prendergast book, um, Psychopharmacology, they recommend increasing the fluoxetine to 50 milligrams, and Prozac is FDA approved for major depressive disorder uh, for the ages 8 to 18. And this patient has experienced some benefit from fluoxetine, but continues to experience depressive symptoms. So, an increase in the medication is indicated. Now, in a teen, um, when anybody have problems, this guy's 14 years old. Uh, he's already on Prozac, uh, I think 40 milligrams, so they're going to increase it to 50. Uh, my only concern with this would be the just precaution would be that this guy is 14, teenager. You have him on an SSRI Prozac. Pro- SSRIs do have that black box warning um, in teens, even though he's a late teen, but still he's kind of in that window. You would have to warn the parents to watch out for more impulsive or aggressive behavior because of because you're increasing it at the SSRI, and you just have to make sure you're not gonna worsen the symptom because of this idiosyncratic adverse um, um, potential with this SSRI in this patient. And the patient is already fairly impulsive with the cutting and the ideation of running into the street. So that'd be something that I'd be a little concerned about. But obviously, they're going to put this person in the hospital and for some time and under observation. So that's just something that popped up in my mind. Diagnostic tests, routine hospital admission laboratory tests should be undertaken. Referrals. Um, cognitive behavioral therapy to assess the depressive symptoms, supportive therapy to address the gender related stressors. I recommend that the patient attend a support group for transgender youth in order to increase peer support. Uh, there's this thing, the Trevor Project. It's a crisis intervention and suicide prevention hotline for lesbian, gay, bisexual, transgender, and queer questioning youth. It's http www.thetrevorproject.org. And before I go on to this, they don't really address the hospitalization in this kid. I think this kid probably needs to be hospitalized. And as I stated before, because we are going to increase the Prozac, the kid's already suicidal anyway, and they have some hardcore symptoms with major depressive disorder. So I would go ahead and put this person in. They're kind of laying out this treatment as though they may release him, and um, the social service department is and the mental health department are giving the family members some options on outpatient, but this person should stay in the CSU or be formally admitted. Um, Refer the patient and family to resume family therapy. Talk to any potential resources, referral resources before suggesting a provider to ensure that the provider is going to affirm the young person's gender. And this is an important point, just to make sure that anybody who professionally is going to work with this individual understands what the situation is and is going to um, work with the patient's identity of who they are and not necessarily challenge that. Refer the patient Refer the parents to local support groups for parents of transgender children, such as parents, families, and friends of lesbians and gays, PFLAG for support group and additional resources. This website is www.pflag.org/transgender. If local parent groups do not exist, consider internet-based resources. Transfamily.org has an online discussion for groups for parents, partners, spouses, and children of transgender people. They also have a discussion group specific for transgender youth. The Gender Spectrum um, organization, www.genderspectrum.org, provides real time online discussions and national phone calls for parents, as well as a number of discussion boards. So there are a number of community based and online support groups for both the patient as well as the family that exists that um, these individuals should be, the individual and their family should be referred to. The type of psychotherapy we discussed above, CBT for the depression, supportive therapy to address gender related stressors, and support community support groups. Psychoeducation, provide education to the parents that gender identity is not something that one chooses or that can be changed. This is an important point. Uh, Conversion therapy, which is therapy that attempts to change one's sexual orientation or gender identity, has been denounced as ineffective and harmful by many professional healthcare organizations, as well as our federal government. Encourage parents to advocate for their transgender child in the school setting if needed. There's several pamphlets. One is answers to parents' questions about transgender people, which can be assessed at the www.pflagnyc.org. website. Um, Other resources for parents would be the Transgender Child, a handbook for families and professionals by Stephanie Brill and Rachel Pepper, and the Transgender Teen, a handbook for parents and professionals supporting transgender and non-binary teens by Stephanie Brill and Lisa Kenny. And there's another book, Raising My Rainbow Adventures in Raising a Fabulous Gender Creative Son by Laurie Duron. um, what standard guidelines would you use to treat or assess this patient? And fortunately, there's a guideline. The American Psychological Association has some guidelines. The guidelines for psychological practice with transgender and gender non-conforming people. This is from the I think Journal of American Psychology, and that those set of guidelines can be obtained there from the APA, the American Psychological Association. Here's some quick clinical notes. Transgender individuals may experience misgendering, um, being addressed as the gender other than the one they identify as a stressor that can actually worsen psychiatric symptoms. And providers and staff should use the name and gender pronouns of the person's choice. So you always want to be cognizant of of using um, what the person expresses himself, the gender the person expresses himself to be, him or her if they want to be a guy, her. I mean, yeah, him or he if they want to be a guy, her or she if they want to be a girl, and that's just respectful and using their gender expressed first name. Um, um, and sometimes that can be quite challenging, but you have to just do a quick check as you're addressing these people and making sure that you're addressing them in the gender role that they desire, uh, and override any impulse to do otherwise. Um, Healthcare providers should be aware of non binary gender identities, meaning individuals who do not identify as either male or female, but by another gender. Some people use identity terms such as genderqueer or non binary, um, which indicates a gender identity outside of the binary male female route or schemata. Transgender people with non binary gender identities may use gender neutral pronouns such as they, them, or theirs. And that's where it gets really difficult. In most cases, uh, uh, these people feel that they may be both genders and are at the same time, and you have to expand your pronoun set, and that can be very challenging. But out of respect, we may need to refer to people as they or them, or use the word theirs when speaking with them. Um, uh, Couple more items I want to just share with you, and then I'll open it up. Um, the other the other book also has treatment recommendations, and I'll go through these real quick. And at this point, I know I've been talking. Does anybody have any questions thus far about gender dysphoria, gender identity disorder, or any comments?
No, I don't have any questions.
Alrighty. So let's go into this second treatment um, recommendations. Management of gender dysphoria should include assessment for recent psychological trauma or co-occurring psychopathology. Um, Disorders such as schizophrenia, psychotic depression, or mania can produce gender confusion in an individual. Approximately 45% of patients presenting with cross gender identification are eventually found to have this as part of another psychiatric disorder, most commonly personality disorders, mood disorders, dissociative disorders, and or psychotic disorders. Studies indicate that anywhere from 33 to 52% of children and adolescents suffering from one or more psychiatric disorders, including are suffering from one or more psychiatric disorders, including the mood disorders, anxiety disorders, and disruptive disorders, in addition to their gender dysphoria. And rates of suicide attempts and self harming behaviors appear to increase within this age population. And that brings up an important point for me. I've worked in several PRTS where they have uh, kids with extreme, behaviors uh, in a residential setting. Um, and most of them are coming in and out of foster care. And I noticed that a lot of the young ladies uh, had gender dysphoria or gender identity disorder, and I didn't know if that was truly a condition that they had, or was it a maybe a defense mechanism, an extreme defense mechanism from being possibly sexually abused and abused because of them being female, and then that they just used um, becoming more masculine as a way to become less of a target in that type of environment. So that's why it's so important before you can make the diagnosis, treat them as such, but you go through an extended period of psychotherapy and counseling with these individuals, especially before they decide to do any sex reaffirming surgery, to make sure that all the concordant diagnoses have been fettered out and treated to make sure what you're left with is a true and, in fact, gender dysphoria, gender identity disorder, which would could lead possibly to hormonal therapy and possibly sex change therapy. Um, Now, according to the minimum standards of the Harry Benjamin International Gender Dysphoria Association, the real life experience of living in a community in the desired role for at least 3 months before any hormonal reassignment, and then 12 months before any surgical reassessment is recommended. So here they give you a window of before as you move down the treatment line, the first recommendation is that you live at least 3 months as in your desired sex role, which I find a fairly short period of time, but that may be just the minimal for someone who's trying to progress all the way down to sexual reassignment and having that end up in some surgical procedure. And um, and if you want to end up going through surgery, they advise that you live um, in that reassigned role, or in the role that you want uh, to be expressed as a patient for at least 12 months. Once again, I find that very short. 3 months before you get hormonal therapy, and just a year before you get sexual reassignment surgery. But those are the recommendations from one of the gender dysphoria associations. When participation in a real life experience is successful, so when you live that in your new role, there's a much higher probability of a positive outcome for sex reassignment. Further protocols of this type Uh, Following protocols of this type, 85 to 97% of individuals report being satisfied with their rehabilitation. The World Professional Association for Transgender Health Standard of Care is the most widely known guide for treating those with gender dysphoria. It endorses psychological evaluation and a staged transition in which fully reversible steps um, occur first. And this is just presenting as a desired gender and living in the community for some time. And prepubertal suppression, um, which is wearing binders or, to cover your breast or um, shaving in males if they want to go from male to female. Um, they should participate in these initially, and then they should proceed to partially reversible procedures, which would be the administration of hormones to bring out desired secondary sex characteristics, and that this then should proceed any irreversible procedures, which would be sexual reassignment surgery. So you just go from living in a community, something that's reversible, to partially reversible, which is the administration of the hormones. And then you would eventually proceed to an irreversible procedure, which would be a surgery. Um, and once again, I think the times for this, they recommend the times 3 months in the community before you take the hormones, and 12 months in the community living as your desired gender before you have any sexual assignment. But I'm pretty sure that most clinicians advise a much longer period of time to work with these patients before they start their hormones and move on to any surgical interventions. Um, it is in the last statement here is it is important to note that these guidelines are flexible and the criteria may vary among medical professionals. Okay. All right. So, any questions thus far on the diagnosis of or the management of individuals that may present to you um, with gender identity issues or gender dysphoria? I got one or two
No
questions that.
questions.
All right, I got one or two. I got some questions here that we can go over that will help illustrate some of the points that we went over. Got a question here. We got a 13-year-old boy presents to a psychiatrist for the first time, and he gives a history indicative of gender dysphoria. He states that he wishes to undergo treatment to suspend puberty. Which of the following steps is most appropriate? And we have five choices. We can screen the patient for psychopathology. We can treat the patient with antidepressant therapy before recommending surgery. Three, we can treat the patient with hormones. Four, we can have him live real life experience in the community. Or E, or five, we can provide ongoing supportive therapy. So you got five options. Um, which one should we pick? Well, the answer is A. We should screen the patient for psychopathology. That should be the first step if someone presents to your clinic. And the explanation here is the management of gender dysphoria should assess for recent psychological trauma or co-occurring psychopathology. Individuals with gender dysphoria have a higher incidence of co-occurring psychiatric disorders, including mood disorders, anxiety disorders, disruptive disorders, suicide attempts, and self-harming behaviors, as well as substance abuse. The presence of significant psychopathology does not prevent proceeding with the transitioning. However, establishing the diagnosis of gender dysphoria should be done slowly, and one should ensure that the um, psychopathology is well controlled so that it does not interfere with adherence to treatment. So the point here is the number one thing you should do if someone comes in with symptoms of gender dysphoria, gender identity disorder, the first thing you want to do is just do a full psychiatric evaluation to rule out any other psychopathology. Um, I have another question here that may illustrate some points for us. Patients with schizophrenia or other psychotic disorders may present with delusional claims of cross gender issues. Which of the following pieces of history would suggest that a male patient's claim of cross gender identity is due to delusions? We have four options here. A, the patient says he feels as if he is a member of the other sex, but does not actually believe that he is a member of the other sex. Two, the patient has felt that he was the wrong gender from a young age. Three, the patient dresses in the attire of the other sex. Four, the patient actually believes he is a member of the other sex. So if you have a person with schizophrenia and they're psychotic and they're delusional, the correct answer would actually be four. The patient actually believes he's a member of the other sex. Um, as part of his delusion, you know, he's not stating I want to be a member of the other sex. He's saying I'm actually, a male when they're female, or they're saying they're female when they're a male, and they actually believe it. So that escalates the gender dysphoria or the gender identity problem to a level of psychosis, and that becomes the overarching diagnosis and not necessarily gender dysphoria or gender identity disorder. So the explanation says gender dysphoria begins at a young age, and individuals with this disorder frequently cross dress. They realize what their physical assigned sex is, but they feel that they should be a member of the opposite sex. Individuals with delusions actually believe they are a member of the opposite sex, even without sex change surgery. So a male who believes he is physically a female, even though he has male anatomy. So that characterization there, escalates it to a psychotic disorder, not just a gender dysphoria. Um, all right, those are just two questions I'd like to go over. I have nothing else to present, and so I can open it up if anybody has any patients that they've encountered like this or they're currently treating, or if they have any other comments about this diagnosis. And the reason I did present this case is, we're in a social climate where uh, individuals may present to you like this, and there may not be very many resources out there for them. So I figured, giving y'all an intro uh, into how you would want to manage these cases, just in case you saw one, because you may be all that there is in the community to kind of help formulate the care plan for them. Anybody have any feelings, thoughts, or cases like this that they've treated in the past or currently treating?
Hi, my name is Betty. I'm actually a future student with Miss Valencia. I was just wanted to appreciate the fact that some of the patients that we've had, the parents having the support is really, really huge. They really struggle with this. because the patients feel very strong. This is how they feel, and the parents are really struggling. So having therapy for the family, I love how you had resources for that. Thank you.
All right, yeah, good. And if anybody wants that information, y'all can just email the office at info@aveniabehavioral.com, info@aveniabehavioral.com, and I can send you a screenshot of the page with all those resources because I didn't even know all those things existed, and that's huge. Any other comments um, or questions or thoughts? Well, I hope that everyone appreciated this case study. Like I said, I've had you see these cases from time to time, um, and a lot of times there are referrals from primary care doctors trying to get trying to get their head around what needs to be done, formulating a care plan. But I think that we may end up seeing more and more of these cases come through our clinics, and this is a way to kind of start getting your head around, some of the one, two, three first steps you should take when you encounter these patients, and like the commenter just stated, getting some resources for the parents going. So because it's more than just it's more than just the patient that's going to have uh, uh, psychological issues. It's the whole family, parents and patients, as well as possibly even some of the siblings. So, if no one else has any questions, I'm going to go ahead and end the case study, and we'll let you know which case we're going to present next month. Okay.